Hi, everyone. Welcome. Grab a seat and get comfortable. You have just entered the Smartest Doctor in the Room podcast, where you can get the best information anytime, anywhere. I'm your host, Dr. Dean Mitchell.
Were you ever stung by a bee or a wasp and thought, will this kill me? Today's podcast should help you know, and most likely it won't, so you can relax. The topic we will be discussing today is the most dangerous type of allergy. It's anaphylaxis. And I'm pleased to have on Dr. David Golden, an associate professor from Johns Hopkins Medical School's Department of Allergy and a leading expert in the field. We will be discussing the newest treatments for anaphylaxis, including the FDA-approved Neffy nasal spray, which is now hopefully going to take the place of the injectable epinephrine.
I want to take a moment to thank the sponsors that make this podcast possible.
I know you may already know from listening to my podcast that I specialize in treating patients with toxic mold exposure. It's become a serious problem for many years as we deal with the hurricanes and floods throughout the country. Even simple bathroom water leaks from a toilet in your home over time can contribute to mold buildup. I can help patients that suffer from the symptoms of toxic mold, but I also rely on the patients getting their current residence inspected so they are not continually being exposed. My go-to person for mold exposure is Joe Reese. Joe is a certified mold inspector with decades of experience. He is super thorough and gives you a straightforward assessment and tells you whether it's safe to live in your home or if there is mold. I should know. I used Joe when I moved to my new home 4 years ago. Fortunately, when I moved in, I smelled an unusual odor in my basement, and I immediately called Joe. He came over with his instruments, and he found the problem. Afterwards, I had remediation, and the problem was solved. Joe does inspections all throughout the country. He welcomes calls to his cell phone at 908-451-4592. You can also reach him by email at jprconsultants7929@gmail.com. Remember, mold in your home is not a good thing, but thankfully it's a problem that can be fixed. Okay, Dr. Golden, welcome. I know we got to meet a week or two ago, which was really nice at a dinner and got to know each other a little bit. And then I found out you're from Canada and you went to McGill University Medical School. And then you did your residency there in internal medicine. McGill, just for our listeners, that's the Harvard of Canada.
Still.
So how did you end up at Johns Hopkins after that?
I was sent there.
I was sent there.
My mentors at
McGill.
Well, they did. They felt that was where I should go to further my goal of getting into allergy immunology. So I went to Baltimore to Johns Hopkins to do my specialty training, my fellowship in allergy.
Interesting. And why did you, at that time, I guess after you did internal medicine, it's funny, allergy is not the most popular specialty, at least I found in the United States back in the day, and especially probably even when you trained, it kind of was, I always tease, I said a lot of people thought allergy was a lot of voodoo stuff back then. So what interested you in allergy at that time?
Well, like almost all allergists, I don't know about you, but I had allergies.
Okay.
It was my childhood allergist that after he was done poking and prodding me, I got really interested in allergies because I was there on a regular basis for my allergy shots for so many years. And in high school, he let me just hang out for a summer and observe the research lab and the clinical work he was doing. So most of all, I didn't actually plan to be an allergist or to go into medicine for that matter. I was really into the immunology and I was in honors immunology at McGill.
Oh, wow.
And all set to get a PhD and continue research because it was really cool. My father said, no way. He said, if you do that, the MD in charge of the lab will always get credit for your work, which is not entirely true, but he had a point there. He said, you have to go into medicine first. I said, all right. I'll do medicine. I'll do my 4 years of medicine, and then I'll go in the lab. Well, 4 years of medicine really changed my thinking about taking care of patients and what I really loved. Not that I love the immunology research any less, but I had a fabulous opportunity at Hopkins to combine the research with the clinical care. Yeah.
Yeah, one of the top in the country, no question about it. It's funny. I heard this story, slight different versions a couple of times where people, colleagues of mine have gone in, said their allergist was a really cool doctor. They liked him a lot. And I guess you're right. They were seeing them quite often with the shots, which we'll get into later. So
Either love them or you hate
we were
them.
fortunate to get you to go into this. So could you maybe explain to the listeners what is anaphylaxis? I think a lot of people have different ideas of what it means. So they get an idea a little bit about, maybe a little bit of the presentation and what's actually happening physiologically.
Well, if we try to keep it really simple, then it's easy
Yes,
to agree what
please.
anaphylaxis is. But but it isn't that simple, which is why experts around the world don't agree on what anaphylaxis is. But at a
Yes.
simple level, it's a severe acute allergic reaction that can be dangerous and life-threatening. So it's considered an immediate reaction. So anaphylaxis, whether there are many causes, we can talk about that, but it's something that comes on very quickly after the exposure, minutes or sometimes hours, but usually a matter of minutes, and affects multiple systems in the body, usually. So besides breaking out in itchy welts and hives, you can have throat tightness, trouble breathing, dizziness, unconsciousness, stomach cramps and diarrhea. So it can really affect a lot of different systems, and that's and in any combination. So one person's anaphylaxis doesn't necessarily look like another person's anaphylaxis.
Right. I think also in my experience, probably like yours, I think what's so challenging for the patient that's experiencing it, um, they don't always associate it, unless they obviously have a known allergen of what's going on. I mean, sometimes, actually, one of the first cases I ever had was a 3-year-old boy that was an asthmatic. This was a dramatic case, and he was highly allergic to peanuts and tree nuts. And his mother told me they were in a little, it's called like friendlier. I probably shouldn't use names. It was a little type of place that you get like a mini diner. And at the end of the meal, and the mother was a terrific mom. She was so careful with him. And they asked, of course, the waitress at the annual, he wanted like an ice cream sundae, and so he was all excited because he didn't have a milk allergy and he wanted to reward himself. And then after like 2 bites of the ice cream sundae, he started throwing up. And turned out there was something called Reese's Pieces, which have peanuts in them at the bottom. And that was the start of it. And I remember the mom, who was very smart, she actually called me and I said, we got to get him to the hospital right away. And then he started breaking out in the hives, which is the classic immediate rashes. And then his asthma started worsening. So there's always like these different presentations. I also knew one also was funny, I'm sure you also get all these hallway consults. There was a friend of ours who she starts to ask me one day, she goes, their cousin, whatever, too, always when they go to a Chinese restaurant is always throwing up after. And I said, well, okay, obviously they need a GI workup. I know, what are you asking me about all this? But I said, but make sure they get checked for peanut allergy. And sure enough, the child had peanut allergy, which, as you know, can sometimes present, whether it's gastrointestinal, the skin, respiratory, before it gets to
Yeah,
that
it can
bad
be
stage.
sneaky. People don't always realize what's
Yeah.
happening until it gets really bad. It can develop over a period of time, 10, 20, 30 minutes or more sometimes. So someone might be fooled initially to say, oh, well, this isn't bad. I've had it much worse before. This is not a big deal. And 30 minutes later, they can't breathe or they're unconscious.
Yeah.
So that's why we talk about early treatment and the need to be really aware of the early signs and symptoms.
Actually, you said something really important, and I want to address something I said right in the opening. I think people get nervous. You see bees and wasps when you're out at a picnic, whatever, and everybody's afraid, myself included. I don't want to get stung. I was once stung by accident. I must have had some gel or something in my hair, and I put my hand back, and before I knew it, the hornet or something stung, or wasp stung me in the head.
Mm.
But I guess people always wonder, are they going to have a reaction? And a lot of times, as you know, too, most people get what's called a local reaction, which is uncomfortable, but it's not a dangerous or leading to an anaphylactic reaction. So I was wondering how you advise patients or how you stratify them. If they call up the Johns Hopkins clinic or your office and they said, I was stung, I got swelling in my hand. Do I need to get allergy tested for insect venom?
Interesting. So, there's it's a little easier to explain, I think, in insect allergy, but it happens with food allergy and other things that
Right.
there are local reactions. and systemic reactions. So local is the area of where it was exposed. If you got stung and your arm swells, that's a local reaction. If you wake up the next morning and it's swollen all the way up to your shoulder, that's still a local reaction. It's called a large local reaction. It is allergic. It's not dangerous, but it can be
Right.
scary and often
People
makes
get
people go to the
afraid,
emergency
sure.
room. Systemic involves your system. It goes through your system, so it affects somewhere in your body distant from the site of the sting. So if you get stung on your face and your face swells up, that's local. If you get stung on your toe and your face swells up, that's systemic.
Right.
Systemic can be mild. Not all anaphylaxis. We touched on this almost a minute ago. Not all anaphylaxis is severe. People automatically associate anaphylaxis, so I'm going to die. That's what your friends and relatives and doctors tell you. The next one
Well,
will
yeah,
tell
you hear on the
you is
media too.
almost
You
never
hear the
true.
worst stories. Right.
Right. But for sure. And every time it happens, it's unexpected, it's scary,
Right.
and
Because you're
scares all of
typically
us.
dealing with young, healthy people in the prime of their life.
Right. It seems comes out of nowhere. But if I get stung by a bee or eat a peanut and I break out in a few hives and my throat feels a little scratchy and maybe I have a little discomfort swallowing, and it doesn't get any worse than that, is that anaphylaxis? Yeah, actually it is. It's a multi-system allergic reaction, but it was mild.
A
Uh,
low grade, I guess we would say, right? It'd be
right. In
low
fact,
grade.
with stings in particular, and it happens with foods, if I get stung and I break it, try telling a parent. This is interesting. Who comes to me because their child got stung, and within minutes they were covered in hives all over their body, and their face swelled and their eyes swelled shut, and they were really scared. And of course, the emergency room said that the child was going to die next time they got stung. And then I say, "Oh, that was nothing. Don't worry. Nothing much is going to happen." They don't believe me. They'll go to someone else because I sound like an idiot if I say that. But again, it's severity is also a matter of we think it's severe if it's dangerous. You can have severe hives all over. It's just not dangerous.
Well,
So
let me stop you on a second because again, you are the like probably the world expert on this because I know also even in my training there was that shift between children and adults. I guess I wonder if it still exists. You'll maybe explain best to the listeners because just for the listeners, again, in our training, we are trying to decipher who should be tested because testing has its risks also. And I remember in my fellowship training, which really is going back also over 30 years now, that the adults, if they had generalized hives, were to be tested. Children were not. Is that still the same? Because I know you were probably one of the people who probably put forth those parameters.
yeah, no, good point. And our sometimes our understanding and perceptions change, or new research comes along. You're
Yeah.
totally right. And this goes to uh, what's a mild reaction and what do we call mild. So if you get stung and you break out in hives all over your body, that's a systemic reaction. It's not.
Mhm.
It doesn't quite meet the definition for anaphylaxis if there's no other part of your body
Right. If
involved,
it's one
right?
organ.
It's one system, and
Yeah.
it's not a dangerous system.
Right.
So it's not, but it's a systemic reaction. It's not
There
just
you go.
local. So the real question we're asking here is what's going to happen next time? Does that breaking out in hives all over mean that next time you're going to have a severe reaction, or you'll just keep breaking out in hives when you get stung, which is not fun, but it's not dangerous. And
Is
and
that
that
your
might
experience? Is that because I'm sure you've seen, again, being an expert on this, seeing a lot of kids over the years who obviously got restung. Is that what was that your
yes,
overall
yeah.
experience?
It was first my pediatric colleagues at Hopkins that pointed out that among the children they were seeing during those early years of research, the majority had just this hives reaction, but they
Mhm.
were worried, and they
Yeah.
did a study over a number of years and showed that the chance of getting worse was actually 2%, less
Hmm.
than 2%.
Right. That's important because
Um,
otherwise all these kids would have been tested, gone
so
through
it
all
was right, and given allergy shots for
and
years.
given injections, which are
Um,
for 4 years or yeah.
And this led to the recommendation that children who have this hives reaction don't really need to be immunized because their chance of getting worse, in fact, their chance of even having another hives reaction was less than 20%, and the chance of getting worse was less than 2%. So uh, the majority, this is what we call shared decision making now. The majority of parents, knowing that, would choose to say, "Oh, if he's only ever going to have hives." and there's a less than 2% chance of getting worse, then we don't really want to bother with years of allergy shots. Maybe we'll carry epinephrine. But there are others who would say, I don't know, 2% chance, I don't like that. I'd rather have my child on shots so I don't have to worry about it. And you know what? They're both right. That's fine. We can say it's low risk, but low risk to me may not be low risk to you.
Yeah, that's true.
So those judgments are made. But in adults, because this is the question you asked, it was always said that adults have more chance of getting worse and therefore should be tested and treated if they've only ever had hives to a sting. But even no formal study has ever actually been done like it was done in kids. When we looked back at research of several studies over the years that just happened to have looked at that question directly or indirectly, it turns out that we don't think the risk in adults is any different than the risk in children.
Okay.
So in 2017, we changed the recommendation. So now even adults who have only hives, we go through that same discussion. Well, it's low risk. You don't really need the shots. If you're really, really worried, or you are a forestry worker and you get stung 5 times a year, then okay,
what will be the answer on a board exam? If adults had just hives, would you refer them to an allergist for insect testing?
That would have been a tough one on the 2017 boards because the recommendation just changed then.
Okay.
Right.
I want to ask you something else too. One of my, I had some great teachers in my fellowship, and one of them actually was at Columbia. He was one of the few very interesting board certified dermatologists and allergists. Because back in his day, it was really funny. He was Dr. Beltrani. He was amazing. He was a family practitioner in practice. He had a big family, and he just got the urge to go back and do training. So he actually got into, he was running his practice and going to Columbia's dermatology residency, as and on Fridays or something like that too, they had an allergy clinic and they needed help. So he used to help out in that. And back in the days, you may know, people could grandfather in if they did a certain amount of hours. And he was a very dynamic teacher. And his mantra, this is my question to you, his mantra, because when he said something, he would say loud and repeat it. And he said, you're never allergic to something the first time you're exposed. I'm just curious what you think about that saying.
Technically true.
Okay.
So your body has to be exposed to an allergen at least once in order to become sensitized, to develop the allergic antibodies. You don't just develop allergic antibodies out of nowhere.
Right.
And there are rare exceptions to that, but that's really pretty much true across the board.
Yeah. I think just
we found that out in some of our research on the bee stings, because when we were doing our early epidemiologic studies, we came across people who had a positive test and they said, oh, I've never been stung. And we said, oh, yeah, give me your parents' phone number. And every single one of them, we could find a relative. Oh, wow. Yeah, he was stung as a kid. He doesn't remember. Yes, you have to be exposed at least once, but it could be once or 1,000 times. So this is where we get into
that was his other thing too.
Right? Or shrimp allergy. People eat shrimp.
That's exactly the example.
All of a sudden, one day they have an anaphylactic reaction. Why? We don't know.
Right. No, that's exactly the example he used to also, his other mantra, like he would say to, because patients would ask him, they would say, an adult would have a food reaction to shrimp, at age 35. And they go, I don't understand this. I've been eating shrimp my whole life. Why now? I mean, he didn't have the answer for that one, but obviously, like you're just saying, the person was getting sensitized and then developed enough allergy antibody to trigger that cascade reaction.
Yes. And frequency of exposure is part of the equation.
Yes.
We see it in kids getting antibiotics. If they get it often, they're more likely to become allergic to it. People who get beekeepers get stung more often. They're more likely to develop the allergy. But the catch is, talking about things we don't understand, they actually may have been sensitized many years ago and carrying the allergy for years and still not reacting.
Yeah.
So having the allergy in your system doesn't automatically mean you're going to react. And that was part of our research for 30 years. And we found a lot of really cool things, but we never actually found that answer.
Interesting.
If you've been following the podcast, you may know I practice holistic functional medicine and immunology. In fact, at Mitchell Medical Group, we've been treating chronic fatigue patients for 3 decades. It's critical in this work to have a trusted pharmacy that can compound medications for our sensitive patients' needs. ITC Pharmacy has been our go-to pharmacy the entire time. They can make medications ranging from thyroid hormones to dye-free medications for all of our highly sensitive, even allergic patients. If you or your holistic doctor are looking for these very specific patient medications, you can contact ITC at 888-349-5453. They have licenses throughout the country and can have medications delivered right to your doorsteps. My patients have been so pleased with their service, and you will be too.
Okay, let's go on to testing. Again, we're staying on the venom, and I think it's important. And we're going to get to the food allergies later for everybody who's listening. Now, as you very well know, venom testing was classically done by skin testing. And I remember in my fellowship having some patients, we did the prick testing, and then later on, actually even the intradermal testing where you give an injection under the skin if they hadn't reacted to the prick testing. But, there was also a small risk of an allergic or anaphylactic reaction from testing itself. And, now we have, I've always been a big proponent of this. We now have the blood testing. There's the Immunocap specific IgE, which is very good. There's component testing. Do you think, unfortunately, our field has been always a little bit resistant to change. Do you think that the blood testing is actually a good way to initiate, testing these patients instead of actually having to do skin testing to venom?
That is actually a much more complicated question than you think.
Okay.
So for the longest time, including the last practice parameter on insect allergy, we're working on an update, which will address that question, incidentally.
Okay.
But traditionally, skin tests were considered to be more accurate. And that may even still be true today. It depends how you define accuracy. Meaning that what we always found over years of research was that of people who have insect allergy, and have a positive skin test, 15 to 20% had a negative blood test. So
was that though with the RAS, the older
it
test?
was good point.
Okay, so just
and it was then with the first
advanced,
generation Immunocap, which was a little better.
Yeah.
Now we're into second generation and up, Immunocap with better sensitivity. So actually, and I don't want to belabor the points of sensitivity and specificity, because it gets really confusing very fast. But the skin test had always been the more sensitive test. Now I'm actually going to say, you know what? The blood test is more sensitive. It can detect really low levels, but that's not always good. You made a point earlier that I really wanted to circle back to, and maybe we can get at it from a couple of aspects. Testing has its own risks. Testing is not benign,
right?
Because testing is not just positive, negative either. Does it mean anything if it's strongly positive or weakly positive? Well, yes and no. We know there are people with very strong positive test of venom who have no reaction at all to a sting, and there are people who have barely detectable allergy by any test, and they nearly die from a sting. So
I've even had patients where they've had a systemic reaction, and it's been shocking. Only a couple through all my years that had almost like no reaction. I mean, they itched, but there was no induration. There's no swelling at the point of the skin test.
Yeah. So we now have blood tests, as you were pointing out, that have been refined. They are more sensitive. But the problem there is that it ties in with what I said, or was, I guess, getting around to saying that there are tons of people who have been sensitized. They have the allergy in their system, but they don't react. And that's true for every allergen. The National Health and Nutrition Examination Survey, NHANES, showed 8.2% of people in this country are positive to peanut, but less than 2% say they can't eat it. So lots of people have a positive test and don't react. We don't know why. That's a Nobel Prize question, right? So, and we found many years ago that if we just went out and tested a random sample of adults, that more than 20% were positive to venom. So we don't have a screening test. And that's why the test by itself doesn't prove anything except that this person's been stung sometime
Well,
in
I
the
mean, but
life.
it's in conjunction with okay. Let's get a little more example
Right.
for a patient.
And then
If
we
I
get
saw a
down to that very
patient,
low level. So the
yeah, I
blood
know, but
test,
the people like who are going for testing have already jumped the first bar because if they, if they've been referred because they got stung, maybe they weren't sure whether it was a wasp or a hornet, but it was a very severe reaction. Their throat closed up, maybe anaphylaxis, whatever. I honestly would prefer to blood test them because if it showed me the results, why should I do skin testing and risk, even if it's 5 or 10%? I don't have that good a lawyer, to defend me.
so first of all, Dr. Mitchell, um, I read about that case in the newspaper, Dr. Mitchell, and it scares the
Really? Oh,
chickens out of
okay.
me. And I've been stung years ago, and I didn't have a bad reaction, but now I'm really scared. So I want to be tested.
Right. Oh, okay.
Well, you know where I'm going with that, obviously.
Right.
You're right. People get referred, and this is all based on their history, but the history is crucial. If we start
Yeah.
testing people who just want to know, we're going to find out stuff we don't want to know. We're going to
Yes,
find out they're
that's true.
positive,
Yeah. Well, that's
which
where you like a good
incidentally can keep them
clinician,
out of the
obviously.
military. If you test a 16, 18-year-old and they're positive, even though they've never had a bad reaction, they're not getting into the military.
Oh, I didn't know that.
Yeah,
Interesting.
just because of that positive test.
Wow.
Then they have to get experts to testify and what. Yeah.
Wow. 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 Yeah, I
So
see. That's
testing is
very
not benign, and a
invasive.
positive test, as we've pointed out for peanut too, a positive test makes people afraid, especially when you give them a prescription for epinephrine. Now they're convinced they're going to die,
Well, right.
right?
Yeah.
Whereas, what does that test actually tell you? Well, that depends on the history. That's true. So I guess the message here is that tests are really important, whether it's the blood test or skin test, but only as important as within the context of the history. Whether it's blood test or skin test, the bottom line is that neither is perfect, and they are actually complementary. They have to be.
Yeah.
So
Yeah.
yes, you can do the blood test first. I have no problem with that, and even if it's very, very low, because there's that range 0.1 to 0.35 that we actually don't know. There's been no
Right.
clinical validation yet. But if the history was pretty strong, then and it's positive, even very low, then you've made your diagnosis. But if it's negative, then you have to do the skin test. And what if it's positive to, I don't know, yellow jacket and wasp, but negative to the hornets? Are you done, or are you now going to do the skin test for the hornets as
Well,
well?
why would you need to? To me, again, honestly, when I do environmental allergy by Immunocap, but if somebody's strongly positive and their history is strong, why test them? That doesn't, to me, that's game over,
I
If I have a
actually
good history.
I agree with you, but there was an article published 3 years ago now that argues that you're going to miss if you don't do both tests in many patients, because if you do your test and something's negative and you don't test it with the other test, then you may be missing something. Well, technically that's true, but were you missing anything that mattered was the
Right,
question.
right.
And that's
Okay.
kind of what you're saying. And
Yeah.
by and large, I agree with you. So,
Okay.
if you accidentally missed the hornets, but you gave them yellow jacket and wasp, are they really at risk? We could spend a long time talking about
Yeah, no,
the
we won't go
activity of
into
the
that. That's
venoms,
too
and
technical. I
but
want to
yeah.
go on one more topic on this, and then we're going to move on. It's going to be a nice transition, actually. Um, as you well know, Johns Hopkins, they have a very famous, I don't know if it's still there, Daisy Labs. Is it still there? Right. I remember because we used to have to send samples there. I did in my practice, when I was evaluating venom patients who were getting treatment with allergy injections for their IgG4 levels. And I want to get into this because I'm just curious to be updated myself. So a patient gets on venom immunotherapy, whether it's to wasp or yellow jacket or hornets, and it's on the therapy for, a year or 2 years. And of course, the big question people always ask, am I tolerant? Okay, these are the recommendations. Okay, maybe after 3 or 4 years, can I stop? And there's one thing that didn't make sense to me, but maybe you can clarify this. Again, I know sometimes we used to reskin test them to see if their skin tests went down, which in a lot of things in allergy, I never see happen because that's IgE. And to me, it doesn't really change very much. But I did always like the idea that Daisy Lab could do the IgG4 levels, which I now can get through Pearl Labs for my environmental and food testing, which I want to get to later. So I want to understand a little bit more because again, you were at the center of the universe for this. What is your perspective on IgG4 levels of what they tell you about reactivity or tolerance after, immunotherapy, the allergy injections?
IgG are so let's start from the basics. IgE antibodies are the allergic antibodies. IgG serve many functions, including having a protective effect against allergies. So
Right.
allergy shots build up IgG antibodies, and that's part of the way it works to give protection. There are at least four different kinds of IgG, IgG 1, 2, 3, and 4. The one that is active in a sense in this regard of giving protection from allergy shots is predominantly the IgG4. So during or potentially after allergy shots or in decision making, if we had the evidence to back it up, which is tricky, if we wanted to know for any reason what protection this person has against honeybee venom, then the IgG4 would give us good information about that. When it comes to stopping the shots, we don't know if any of these things actually matter. There are other risk factors, if you will, that are clinical, but none of the skin tests or blood tests seem to predict very much. But there is research showing that IgG4, even though it does go, when you stop the shots, the IgG goes way down back to so-called normal levels. Does that mean the protection disappears? No, it doesn't. There are other factors involved, but IgG4 may be one of them. Even though only a little bit sticks around, in Steve Durham's research, it actually was a strong
Right.
correlation with
Right.
lasting protection. So I don't think we know enough yet to say whether measuring IgG4 is going to tell you whether you're the person who can safely stop shots or not. We don't actually have a test technically that tells us that. We have some factors and tests that tell us that you shouldn't stop, like the tryptase.
Oh,
So
interesting.
it's hard to give you an exact answer on IgG4. There's some things we know about it.
Would you
In a
describe it
broader
though as
sense, I
a
think we know
blocking
less.
antibody or a
Sorry?
neutralizing antibody? Like, what is it? I mean, if the mechanism is well known, does it block the site where the IgE is going to bind from the venom, or does it actually kind of catch the venom IgE and almost like Zolair and just kind of like hitting like an asteroid in space?
It's a combination of things, actually, because it does compete with the allergen
For the sites.
for the binding sites because it captures the allergen, if you will,
Mm-hmm.
before it
Okay.
can get to the mast cells to release histamine. But it
Okay.
also binds, the IgG4 antibodies also bind with regulatory T cells
Mm-hmm.
and actually are active in the regulation of the immunity. And that may be part of the reason that they are a marker for protection and for lasting protection. So again, Steve Durham has those assays, FAB, facilitated antigen binding, which is what the IgG4 does. It facilitates antigen binding to regulatory B cells and T cells. So it is complicated. It is kind of interesting, but knowing that is all the more reason to think that there should be ways that we could leverage IgG4 testing to tell us more about people's risk of reaction.
Yeah, I use that a lot actually now too for following people on food allergy treatment, which I'll just mention later.
Uh-huh.
I want to go into the anaphylaxis treatment, but honestly, I want to go a little bit deeper. I'm just curious of your experience. Again, a patient has, recognizes having an anaphylactic reaction. Back in the day, would give themselves an auto-injectable EpiPen or Anakit, one of those products. But we were discussing this at dinner a couple of weeks ago. Unfortunately, all too often, patients go to the emergency room or urgent care, and they're just given Benadryl and cortisone. They're not given epinephrine, which I think we both agree was a big mistake. So actually, I'm really curious because I know I've read sometimes cases from Hopkins. I'm curious about a more severe reaction. Let's say a patient has given themselves the EpiPen 5 or 10 minutes before they came into the emergency room at Hopkins. How would you assess and treat them? And they're still having issues. Their blood pressure's low. They're still wheezing. How would you
Okay.
treat that patient?
So if they still have signs of moderate to severe anaphylaxis,
Yeah.
then, and it's been 5 or 10 minutes, then they need another dose of epinephrine. So right off the
Okay.
bat, before I do anything else, I'm getting another dose of epinephrine into them. And based on what you were just saying, and in many cases, We don't talk about this much, but it's equally important to start intravenous fluids. Actually.
Yes. Thank you for you reminding me. I mean, it's kind of something that's not emphasized, and maybe explain to the listener why that's important.
A lot of things happen in anaphylaxis. So you can have low blood pressure, and epinephrine will raise your blood pressure and get you back on track, hopefully, if all goes well. But there are other things that happen. There's the blood vessels become leaky. You actually have third spacing, the fluid extravasation. So
Right.
fluid is lost from the circulation. That doesn't leave a whole lot in the circuit, so to
Right.
speak. And even after giving epinephrine, you can still be confronted by this hypovolemic shock. There's just not enough blood in the circulation to
Okay.
help this person. So they need to be filled up with fluids that will stay with it in the circulation and allow them to actually get their blood pressure up and perfuse their bodies.
Yeah, I think that's so I was reading again. Also, it reminded me, sometimes we forget these things. We're so busy with giving drugs. And there was definitely a case report or something in one of the journals that reminded me of that. And I said, gosh, that is so important. I'm sure also sometimes in the field, maybe the paramedics start that, not realizing how beneficial it is. And I'll tell you something else interesting too. When I was giving allergy shots in my early days, because later on I just did sublingual, I think I mentioned to you.
Yeah.
I had a young boy who I had given a dust mite shot to, and he went in. It was his second time. The first time he had a mild systemic reaction. The second time it was full blown. And I gave him the epi, and he wasn't really responding great. And of course, I called 911. But it was interesting. What I did the second time, I gave him 100% non-rebreather oxygen, and
So that's
that
the third thing.
really,
Correct.
right?
So
And that,
epinephrine,
again, so
IV fluids, and oxygen. And people
yeah, I
forget
mean, because it
about
just
those things.
helps his oxygenation. He went from looking blue to looking normal, and by the time the paramedics got there, he was pretty stable. But it told me,
And you
like,
notice none of those top three things included antihistamines or
well,
steroids.
I was about to ask you, so where do those come in? Because as you know very well, I mean, I constantly see people get cortisone, which won't work for an hour, till it kicks in. And the
Or more.
antihistamine, actually, I only heard people say, the allergists that I respect say, oh, we only give it to kind of offset the shakiness from the epinephrine.
It has no role at
There's no
all.
role. Okay, so
It
I
may
mean,
increase risks in some ways, as you know, depending on the person, if they have diabetes, if they have, there's so many negative things about steroids. And this is, as we started at the beginning saying, this is an immediate hypersensitivity reaction. Why are you
yeah,
giving a drug that doesn't even start to work for a couple of hours?
right,
Even antihistamines, they're busy giving, intravenous diphenhydramine, Benadryl, and that's not going to work for at least 30 minutes. And epinephrine works in less than 5 minutes.
right. Yeah, we're
Uh,
going to get into that with some of the things. I have one quick question too. I do have sometimes patients that have a mild reaction to any of these things. I have them do a Claritin and Ready tab on their tongue. So I feel like it's very quick action. Do you think for very mild reaction, an antihistamine is reasonable?
Absolutely. And at the
Okay.
beginning of a reaction, if you're itchy, if you're starting to break out in hives, actually at that point, that's a difficult decision, right?
Yeah.
Uh, am I going into anaphylaxis? Do I use my epinephrine
Right.
or just take an antihistamine? Because antihistamines do help itching and hives. That's
Yeah.
true. It'll take 20, 30, 40 minutes depending on the medicine. And you're
Yeah.
right. Uh, Having it sublingual or chewable will hopefully
Yeah. Work a
accelerate
little faster.
absorption.
Yeah.
So I think that's a great idea, but not if it lulls people into thinking, okay, well, I took my antihistamine, so I don't need to use my
Right.
epinephrine.
Right. Right. Okay, let's make a
Antihistamines don't prevent
transition.
anaphylaxis.
Yeah, well, let's make a transition. We met for dinner because we're both really excited. Because I think for the first time in 100 years, and I'm not kidding, I think 100 years, epinephrine is now available, not as an injection, but now as actually a nasal spray called the Neffy device, which is pretty exciting. I mean, I'm amazed at how many patients don't know about this, but when I tell them, the parents and the kids are to the moon. They're
Mhm.
like, oh my God, I don't have to carry around this injectable anymore. And, I have to get a shot to get better. So, but, of course, the first question I get, and I'm sure you get also, is it as good as the injectable epinephrines? What's your answer?
I have to say yes,
Okay.
but I have to say technically we don't know.
Right. I mean,
Because
it's not
how do
been
we
born
know that
yet.
it works, right? Well, it normally in any new medication. There are controlled trials, placebo controlled. But we can't do that. We can't give
No, it's not
placebo to someone in
ethical.
anaphylactic shock. So there was an alternative pathway available at the FDA that basically says that, we have these other products that are approved, and they've been around for 100 years, like you said, and we know they work. We're going to trust our experience on this. We know epinephrine works. We certainly know what happens if you don't give epinephrine, put it that way. And we know we can measure epinephrine in the blood. We can measure the heart rate and pulse. We know what epinephrine does when you give it in a needle. What if we had a nose spray that did those things, that we could measure it in the blood and it gets to the same range as the needle, and the pulse rate and blood pressure go up. It does all the same things. Should we expect that it's going to work the same? Well, we do. But there's no clinical control trial. Now, over the coming months and years, we'll start to hear and see the experience of people reporting and studies reporting what happened when they used it 50 times, 100 times, 1,000 times. Will it work every time? No, neither does the needle.
Right. Well, what I'm telling patients, honestly, too, it's just the delivery has changed. And, I also like to give the example, like when I was in residency in internal medicine, we had, especially in New York City, a lot of people coming in with overdoses or suspected overdoses, and we used to inject Narcan in them. Well, now today, Narcan is available anywhere as a nasal spray to help reverse an overdose. So it doesn't seem like it shouldn't work. And insulin, I mean, again, that could have been a little bit of a political thing. Insulin was given as a nasal spray instead of having to be an injectable. I don't know why
there are numerous examples,
by the
migraine
wayside,
medicines.
but I guess because it's a continuous medicine.
And not to miss the chance to point out, since you mentioned it, that Neffy has the same device, is the same device as Narcan.
Oh, is that right? Interesting. Yep. Yeah.
So people ask, how will I know how to use it? Well, you can get Narcan over the counter. It's pretty intuitive. It's anybody should be able to pick it up and use it.
Right.
It's the exact same device as the Neffy device.
Yeah. Just so we're pointing out too, I think it's so important. I tell patients all the time just to be careful because they're so used to allergy nasal sprays, where they spray it a couple of times, and you can't do that with the Neffy. You lose the medicine. And also, what I found interesting, I'm not really sure why, but apparently, because I always take time to, and I learned this from one of your colleagues at Hopkins. No, it was Michael Callender at the NIH. I'll never forget, I was at a meeting once when they first came out with a lot of nasal steroids. And he said, he goes, make sure your patients angle the spray to the side of their nose so they don't get an ulcer or whatever. There's been lawsuits about all that. So I would take the time. But now with the Neffy, you have to really instruct the patient the spray goes straight up into the nose, not angled.
We actually don't emphasize that. All we say is that you don't have to angle it like we say with.
Oh, is that right? Okay.
Right? We don't say you have to do it this way or that way. Just fit it in your nose and spray it. It's a fine plume. As long as it sprays in your nose and not in your eyes, it's going to get absorbed properly. And so it's really not. But the first thing you said is very important for people who have used allergy nose sprays. Even though we tell them not to prime it because they're wasting doses, they do it anyway.
Yeah.
But in this case, if they do that, they've lost the dose. And
right. That's it. Yes. Please, for listeners, be aware, because again, I think more and more people are going to hear about this, and it's going to become the way things are done for sure. First line. Is there anything, that you're worried? Well, let me ask you this too, because again, it did change a little bit with COVID. I don't know if it reversed, it was like you gave yourself an EpiPen shot. You were supposed to go to the hospital to be observed. What is the ruling or anything changed? You give yourself a Neffy spray and you should still go to the emergency room, or can you, wait 30 minutes and observe yourself?
Not only has the recommendation changed, but it's actually now even in the Neffy package insert.
Okay.
And you're right, it all started with COVID, because we didn't want to send people, and people didn't want to go to the emergency room.
Right. They were
so if they had a food reaction,
COVID versus the allergy reaction, right?
Right. So there were interim recommendations back in 2020 that if you had an anaphylactic reaction and you used your epinephrine, that as long as you used it quickly and it worked and you were okay, you didn't actually have to call 911 or go to the emergency room. Mm-hmm. So a couple of years ago, we in reviewing this, doing our updated practice parameters on anaphylaxis, we decided to actually make that recommendation permanent. So it's now a recommendation with a lot of conditions. It's a recommendation, and there's a whole list in the practice parameters of people who are good candidates and maybe people who are not the best candidates for this plan. But it opens the door that if you use epinephrine right away and it works well, and you clear up and you stay clear, you do not have to call 911. And I said that it's in the package insert because now instead of the language that says, which is, like in the EpiPen, if you use the EpiPen, call 911. In Neffy, it says, counsel the patients on when to activate emergency or to seek emergency medical services. Not you have to, but discuss with the patients
Makes
when,
sense.
or when yes, when no. And that's going to be very patient specific. Someone who had life-threatening anaphylaxis and needed 3 doses of epinephrine. Yes, I want them to call 911 immediately. But we have to disengage the epi from the 911.
Right.
Because you probably heard it.
Well,
I
that's what
have
holds
people who
people
said,
back.
well, I didn't use my epi because I didn't want to call 911. Or I
Right.
was
I mean,
out
that's
in
so
the
important what you're
wilderness.
saying. People like their parents, everybody are holding off. Like, give the shot. I have to. I'm a bad parent if I don't call 911, et cetera, et cetera. And
But it
yeah, so
actually
I
kept
mean,
people
look, it makes
from
sense. That's what I'm talking
using
about.
it.
It makes sense in allergy and everything. You have to advance. I love that line from Max Planck. Medicine advances one funeral at a time. That can't be the case. And we're talking about the doctors dying, not the patients. I want to ask you one last thing as we're kind of getting a little bit toward the end. I'm not sure if this is in your roundhouse, but I'm just curious what you think because you're such a smart guy. Obviously the main uses of a Neffy would be for anaphylactic food reactions. It seems to trump over insect sting, these days. And, I think that all of us have as doctors, have the duty to inform our patients there are now options. Now, there's the oral immunotherapy, OIT. There's the sublingual immunotherapy, which I do. There's actually now Zolair injections. If a patient came to your office and has had a few dangerous anaphylactic reactions to tree nuts or peanuts or whatever, shrimp, do you have that discussion with them that, okay, there are options now that maybe should be considered?
Oh, absolutely.
Yeah.
Absolutely. They deserve to know that there are choices, and they can ask me all the questions they want, and the questions that you ask. They're going to ask me, how new is it? How do I know it's going to work? Everybody talks about the EpiPen. Isn't that like the gold standard? So we need to have that discussion, and I get all different answers in that discussion about why they might want this or that. But the people who a lot of our patients have had that prescription for the needle from the emergency room, from their family doctor, or whatever. The question is, when they had a reaction subsequently, did they use it? Number one. Did they use it promptly? Number two. Aside from the fact of whether they even were carrying it and had it with them, right? So, and I'm saying that because even Neffy is not for everybody. The person who tells me that, oh yeah, I used my EpiPen and it worked great, and I have no problem using it. I've had patients like that, and I trust it because I've used it and it
No, I
worked.
understand that.
I don't
Right.
want Neffy. You know what? Why should I give them Neffy?
Well,
As
I mean,
long as I
I'm
know
asking
and
about
believe they're
being
going to use that
proactive,
EpiPen.
though. I'm talking about being proactive because, again, it's very hard to go through life worrying, God, that next meal could throw me into the emergency room or worse.
So, are you asking whether everybody should have one?
No, no. What I'm asking is if you're with the patients that you're seeing, because I know the ones that I'm seeing, that parents especially for the children and even adults who are who had a bad reaction in Europe because there was a language problem, who was allergic to peanut, whether they should have the option of getting Zolair injections or getting sublingual immunotherapy drops. That's what I do because the
Yes.
patients that I'm seeing, the way I differentiate from OIT, because my patients, especially a lot of the adults or college age kids, they don't want to sit for hours going through OIT, which is effective, the oral. The sublingual, I give them drops and I explain to them, my goal is not to allow you to eat peanut butter and jelly sandwiches. It's to allow you to go to a restaurant and not worry if there's a peanut or two in your salad, you're going to end up in the emergency room or worse. And of course, now with Zolair injections, that's also raising the reaction threshold. So I was just curious in your practice, because I think it's still very slow in the uptake. The insurance companies are giving, some of the families a hard time, but whether or not this is a very good proactive way, to protect patients.
So I guess I'm still not sure what you mean as far as
Well, I'm
who
asking, do
you would
you,
give it to.
a
Like
patient comes to
proactive.
you, a teenage kid who's about to go to college.
Okay.
He's got multiple food allergies, peanut, tree nut, sesame. His mom says he's got to be so careful, when he goes to a
Right.
restaurant with his friends.
But
And
he
okay,
already
and you
has an
have
EpiPen?
what? And he has an EpiPen. He carries around an
Okay.
EpiPen, but he's still worried. And his mother's worried when he goes to college if there's a little bit of drinking going around or this and that, whether he carries his EpiPen with him. I mean, not everybody, has it, sewn into their hip. Would you advise a parent saying, look, you may want to consider some of the proactive immunotherapies or
So
Zolair?
sure. And absolutely.
Yeah,
Listen, having epinephrine is great and critical oftentimes, and using it promptly. I can't emphasize enough that the longer you wait, the less it works. So the beauty of Neffy to me is that people are probably not going to wait like like they wait with the needle to see if they get worse because
but
they
and
really don't
Melanie,
want to use it.
I'm
They're
sure
going to
from your
use it quickly.
experience.
So that's one of the beautiful things that, if you use it promptly. But so what? If by the time you need to use your epinephrine, you're already having a reaction.
And with
If
young
you were
people
on
as well, they don't
immunotherapy,
carry
you
it.
wouldn't even be having a reaction.
Right, right,
So yeah, well, so first of all, for the public and doctors and everyone else who's not an allergist, venom immunotherapy exists. 95% of our colleagues that are not allergists don't know that.
right.
So yes, we can, in many cases, with almost 100% efficacy, we can prevent insect sting anaphylaxis. And now with the options like what you were getting at, this is an amazing world we live in now.
Right.
We can offer people Zolair. We can offer people oral immunotherapy, sublingual immunotherapy, epicutaneous immunotherapy is on the. I mean, we're at a stage where I'm not saying no one's going to need to carry epinephrine, but most people with food or insect sting allergy shouldn't have to worry about whether they're
Right.
going to have a reaction and need epinephrine.
Yeah, I agree with you because I once went to, I think I was telling you, I went to a meeting at Mount Sinai which was just all mothers. I snuck in. It was mothers of food
That
allergy
must have been
patients,
tricky.
and they were some of the smartest, most caring mothers I had ever seen. And but I do know from personal experience with, taking care of their children and dealing with them that they carry a heavy load. They're always
Mm.
worried their child could be in that
Hmm.
situation, maybe not have have the epinephrine on them and or just be compromised in some way. And now I do strongly believe that there's better options than ever. And I'm really, as I said, I'm really super excited about the Neffy because again, I think kids and everything, they can just spit that in their pocket real easy. They don't have to carry a fanny pack. And this could be a way of life. But Dr. Golden, is there anything else you'd like to mention before we finish? Anything maybe we didn't cover, even though I know we covered a lot?
We did cover a lot, and I think you've probably brought out everything that I was hoping to touch on. I'm trying to think about any, one of the fun areas. So now we're just getting into a tangent, but you had asked me at one point about unusual allergies.
Yes, I
What are the
actually meant to get
weird
that. I
things?
want to cover so much, but I'm glad you're bringing that up at the end. Yeah. Tell me one of your fascinating cases.
Well, you and I talked about being allergic to sex, which is
Yes.
a thing. There are actually three different ways.
Maybe I should have opened the podcast with that. We've got a lot more listeners, but
Fatal
go ahead.
attraction, two, one, two, and three. Um, but there are actually three different ways of being allergic to sex. You can be allergic to the seminal fluid, which is what we were talking about, and that's a thing. And you can actually get immunized for that too. It's been done. You can be allergic to the exercise involved. It is exercise, at least for some people,
Yes.
and you can be allergic to, depending on the exposures these days, to latex, whether
Yes.
it's a
That's correct.
condom or IUD or whatever. So there are actually three different ways. There's so many exercise. The concept of being allergic to exercise really, people love that idea until it's them that's affected. Being allergic to exercise is not fun. It's one of the most difficult things that I see because it's always the high school athletes and marathon athletes, and the high achievers who have that problem. But then there are the hidden foods and the natural food allergens. You may know what pancake anaphylaxis is, but a lot of people don't.
What is that?
Pancake anaphylaxis,
No.
that's where the pancake mix has been sitting on the shelf in the pantry all summer.
Oh, it has dust mites in it or something?
It does.
Right.
Dermatophlebitis
I know
farinae
stuff.
are in the flour. And then the highly dust mite allergic
Yes, right.
person makes
Yeah, that's an
pancakes
interesting one.
first time in the winter and has anaphylaxis to the pancakes. Yep. Um, and then, of course, going back to insect stings, um, for, even if you're not allergic to insects, you might want to think about this. But I hear this every year, people who were stung on the tongue or in the mouth as they were sipping from a straw or soda can or beer
Yes,
can.
right. You got to watch
Yellow
that
jackets
thing.
are just the right size to fit in those things.
Oh,
And people,
oh.
so yeah, that's just something you might want to
Well,
avoid.
actually, I have to go back to the sex thing for a second because I do have one story out of all my years of allergy. It was early in my career before I was doing sublingual drops. I was giving allergy injections, and there was a woman in her early 30s came in. It was early in the day. It was like, like around 1 o'clock or something, and she came in for her allergy shot. And she waited the 15, 20 minutes, and then she went home. And then about an hour and a half later, she calls me. She goes, "I'm covered in hives." So I said, "Oh my God, you're getting a delayed reaction." I said, "Come back in." So she comes back in, and I'm like, "This is really strange," because most of the time the reactions happen. I mean, it can, but most of them happen, within the first 15 or 20 minutes. So we're talking. I'm saying, "Did you do anything? Did you drink alcohol?" I'm always looking to see if something else triggered it. She goes, "Well, I did go home and have some relations with my husband." So I said,
Yeah.
"Oh, you're
That
saying
goes
that was a little."
absolutely.
That
That
set
goes
it
to
off.
the exercise, and people don't think of it as exercise, but we've we're aware of it. We counsel patients oftentimes not to exercise for an hour or two after their allergy shot.
Yeah.
But yeah, I guess I'll have to add that to my list.
You have to add that to the list.
Yeah.
Well, Dr. Golden, I want to thank you for your time. I want to thank you for what you've contributed to the field of allergy over all your decades in the field and your research. You are a giant in the field, and I've been really honored to meet you and have you on the podcast.
My pleasure. Thanks for inviting me.